Thank you for allowing us to present our work on an evaluation of pediatric transfer over triage in a mature trauma system. We have no disclosures. Dedicated pediatric trauma centers are a valuable resource in the care of the injured child. Overutilization of these facilities could subsume limited resources and increase costs. Secondary overtriage results when a patient is transferred from a facility to a trauma center. Pediatric secondary overtriage rates are over 20% in the literature. We sought to evaluate the pediatric secondary overtriage rates in Pennsylvania, and we hypothesized that pediatric overtriage would constitute a significant percentage of admissions to pediatric trauma centers. We retrospectively queried the Pennsylvania Trauma Outcome Study database from 2003 to 2017. We included all trauma patients less than 18 years of age who were transferred to an accredited pediatric trauma center in Pennsylvania. Those patients who presented dead on arrival were excluded. Patients were then stratified into early discharge, defined as less than or equal to 24 hours, or late discharge, defined as greater than 24 hours. In this study, we defined pediatric overtriage as patients transferred to a pediatric trauma center with an early discharge. Multi-level mixed effects logistic regression was performed, controlling for demographics and injury severity covariates. 37,653 patients met our inclusion criteria, with 49.8% of these falling into the pediatric overtriage category. Non-pediatric overtriage patients were more severely injured compared to pediatric overtriage, with an injury severity score of 10 versus 6. Additionally, these patients spent less time in the emergency department at 181 minutes versus 207 minutes. Other variables found to be a decreased risk of pediatric overtriage included femur fractures, child abuse evaluations, plastic surgery consults, orthopedic consults, and ophthalmology consults. Conversely, those variables which were significantly associated with pediatric overtriage include closed skull vault fractures, supracondylar humerus fractures, concussions, and neurosurgery consults. While not all of these injuries necessarily required a transfer to a pediatric trauma center, some, such as the supracondylar humerus fracture, requires specialized pediatric orthopedic care, and thus while transfer is required, this patient still may go home with an early discharge. So in conclusion, pediatric overtriage comprised 49.8% of pediatric trauma center transfer admissions in Pennsylvania's mature trauma system. Improving community resources for pediatric concussion, mild traumatic brain injury, and isolated skull fracture management may result in decreased transfer rates to pediatric trauma centers. Development of better interfacility transfer guidelines and education for adult trauma centers and non-trauma center hospitals is needed to decrease pediatric overtriage and therefore protect the scarce resource of pediatric trauma centers. Thank you.